Hello, my name's Trent Yarwood, and I'll be speaking today on the uses and reasons to be cautious about data linkage in public health. My talk today will be a more computer focused and slightly more technical talk than some of the other talks that you've heard today. But by way of background, I am an infection specialist working in the public health systems. My disclaimer is that these are my personal views and those of FutureWise and not my employers in the Queensland Government. So, you've probably heard talk about big data. It's very trendy at the moment, and lots of people talk about research on big data and how the government particularly is very focused on using population data that we generate to improve the delivery of government services. So big data is really big. Every single thing that we do these days generates lots of data. A figure estimated by IBM is that we generate about 25 million terabytes of data collectively in the world per day, and for comparison, the hard drive that you buy for your computer these days might be 1 or 2 terabytes. So where does all this data come from? Well, if you think about how much of our lives we live in the digital world now, your phone, it records where you go and who you've called and what you're doing with it. If you post information on social media, if you have an exercise tracker like a Fitbit, then all of these devices generate data. You can see in the screenshot I've got on this slide, this was just an afternoon, my use of my mobile phone, and that information is all recorded by my phone, and because it's an Android phone, all recorded by Google. Of all of the different interactions that you have through the day, just how much data that we generate. And so when we use the term big data, using all of this data that we generate and looking for trends, the two different ways that we can use this sort of data is looking at your own data over time, but then also comparing the different data sets between individuals. So how does one person's data compare to another? Part of the problem with all this data is that much of it is collected by individuals with particular commercial interests, and they keep that data for themselves as part of their doing business. And so Facebook collects lots of data about it, and Facebook uses that data to put ads in your Facebook newsfeed. But there's not a lot of crosstalk those data sets because it's considered to be commercial in confidence. So how can we use big data in healthcare? Well, as you've already heard in the talk from Jeremy McAnulty, one of the ways that we've been using this data for many years is in the collection of population health statistics. So that gives us an idea about patterns of disease, about disease outbreaks, but also it lets us do health service planning. One of the developing areas of the use of big data in healthcare is how an individual's data can affect their risk of developing disease and be used in diagnosis, but also used in clinical therapy and in prognosis of disease. So one example of this was a collaboration between DeepMind, which is an artificial intelligence company in the UK, which was bought out by Google, and the Royal Free Trust in the National Health Service in the UK. So DeepMind did a partnership with Royal Free and essentially mass analysed the healthcare records that were generated at Royal Free, and on the basis of those medical records they then developed a program that would monitor patients' blood test results. You can see in the picture there that it analysed about 2,000 blood tests a day, and one of the things that it was particularly focused on was detecting changes in kidney functions that happened. An acute kidney injury, or AKI, is a serious in-hospital complication if it's not recognised. So what this system did was that it would automatically monitor patients' blood test results, and if it detected a significant change in a patient's kidney function, then it would send a message to their supervising consultant directly, who could then log in on his computer from home or on his mobile phone or her mobile phone, or come into hospital if it was required to review the patient. And you can see there that in a day then there were 11 cases identified potentially of serious clinical incidents. So another example also linked to Google, in the United States, they have a medical big data research team called Medical Brain, and they published this study in Nature Digital Medicine in 2018, where they analysed the records of about 110,000 patients, and from those records they collected about 47 billion points of data. What they then used, they used all this data to try and create models that would predict patients' risk of various hospital outcomes, and you can see them there. And in medicine, we have ways of clinically predicting these things, scores based on patients' blood pressure and heart rate for mortality, and on their range of other medical conditions for length of stay and readmission. And I've got the figures there of what's called the area under the receiver operator curve, which you don't need to understand, but it's essentially a way of assessing how well a diagnostic test performs. And so if you've got an area under the ROC of 1, then the test predicts perfectly. If the area under the ROC is 0.5, then it's basically about as good as flipping a coin. And so you can see there that the numbers are all close to 1, but that in fact all of them performed much better than our traditional medical clinical tools for assessing people's outcomes in hospital. So I guess this is just to say that there are definitely clinical benefits that can be accrued from the use of big data in healthcare. So what's data linkage then? So big data, as I've said, is about analysing these data sets that we generate in our day-to-day life. Data linkage is when we take these large data sets and merge them together based on some sort of common identifier. And what we then do is we look for associations in the combined data set between things that we might not have seen looking at the individual data sets. So again, coming back to one of Dr. McAnulty's examples, you can look at birth outcomes and immunisation rates and see if those affect the rates of communicable disease, which would be no surprise to say that they probably would. But what you can then do is link this with the data from the state education departments and see if having a childhood communicable disease, say, has an impact at a population level on your long-term educational achievement. So that's the sort of public health research that can be done through linking health data with other administrative data sets from other spaces. So this sort of research has happened in Australia already. The most famous example is the discovery of the link between folate intake in pregnancy and the risk of neural tube defects, including spina bifida. More recently, they're using the data on drug prescription via the Pharmaceutical Benefits Scheme. There was a group in Sydney who looked at the rate of prescription of cholesterol lowering medications called statins, following a documentary that was aired on the ABC calling into question their efficacy as a clinical treatment. But what the study showed is that in the weeks following the airing of this documentary, which presented a controversial and, in my opinion, incorrect take on the risks versus the benefits of taking statins, there were 14,000 fewer prescriptions for statins in those few weeks without a significant similar change in a different medication. And so looking at the population health impact of high cholesterol and heart disease, people were able to estimate that if that reduction in use had been sustained over 5 years, it would be responsible for somewhere around 2,000 additional, preventable heart attacks or strokes, some of which would have been fatal. So what sort of benefits could we get out of combining whole genome sequencing of drug-resistant organisms along with patient data? So these are just some examples that I've brainstormed while I've been writing this talk. And you can see there that you could look for the risk of a patient acquiring an infection due to these drug-resistant organisms. So for example, how many times they've been prescribed an antibiotic in the community and whether that means they're more likely to develop a drug-resistant infection. Whether being in hospital frequently or seeing their GP frequently is a risk or a protective factor in developing drug-resistant infection. We know that overseas countries have much higher rates of drug-resistant organisms than Australia does, so we could combine this data with immigration, with customs data, see whether your frequency of overseas travel increases your risk of colonisation with a drug-resistant organism. And there's also the potential for linking with genetic susceptibility data. So at some stage in the future, it's possible that we could link this sort of data and see if there are individual patient factors that increase your risk of getting a drug-resistant infection. Obviously, doing whole genome sequencing is an excellent tool for public health surveillance, but it also lets us see what the pattern of drug resistance is, so it helps clinicians work out which drugs they should be using in the event that there is an outbreak of these drug-resistant infections. And also it obviously lets us see what happens in terms of clinical outcomes. Similarly with the Google hospital data, we could see whether there are risk factors for having bad clinical outcomes, what the likelihood of patients having a relapse or a reinfection due to their drug-resistant organism is based on their health status. So, in terms of some of the reasons that I think we should be cautious about data linkage research, number one is whether we are truly gaining informed consent from patients who are taking part in this sort of research. Then there's issues around how well the data is de-identified, whether it can be used to identify individual patients in the way that it has been de-identified, and if then it can be re-identified either through direct methods or through linkage with other data sets. There are issues around the storage and security of our personal health data, and some of the risks to privacy and to patient data that come around through the use of data linkage research. So you will have heard in some of the other talks that obviously when we do research on that, we gain informed consent from them in almost every circumstance, that this is an important principle of clinical research, and it revolves around researchers making sure that the research participants understand what the risks to them of participating in the research are, but also what the potential benefits to them, if there are any, but to society at large are, as they make their decision whether to take part in research or not. The Declaration of Helsinki is the World Medical Association statement on research ethics, and I've got a quote from it there where you can see that it applies to research involving human subjects, and it should include research on identifiable human material and data. Now that's an important caveat, because in many circumstances ethics research is overseen in institutions by ethics committees, but if as researchers demonstrate to the ethics committee that the research is low risk, that there's no chance, in inverted commas, of patient information being re-identified through the research material that we collect, so we're not collecting patient names, it's just purely administrative data, then we can have our research approved under a low risk ethics exemption where we don't require individual patient consent. And that's generally the case only where there's no chance of re-identifying patients through the data that's been collected. Many bits of big data and data linkage research do get through under this low risk ethics approval process because the researchers take efforts to ensure that the data is not re-identifiable. So what does informed consent mean in terms of research consent? Well, it's really tricky, because to give informed consent you have to really understand what the benefits are and also what the risks are. Now I've got a quote there from some computer scientists who say essentially that in medical publications on data linkage research often don't have the same understanding of data security and privacy that computer scientists do, which is not surprising. Related to this, the RACGP, the College of General Practitioners, have said that they don't really think it's appropriate for GPs to be the gatekeepers of informed consent for my health record, because it takes a lot of time, because it's technically complex, and there's this conflict between providing a clinical service and providing getting informed consent, which can often be a slow and complicated process, because you really need to make sure that your patients understand what the risks and benefits of the procedure that you're consenting them for are. But the challenge is, which is highlighted by that quote there, is you can't really get informed consent from a research participant or from a patient if you don't really understand what the risks are yourself. And I think doctors are good at being doctors and maybe not quite as good at being computer scientists, and that this is really important, that if we as practicing clinicians and researchers don't understand the technology very well, then we're not able to obtain good informed consent, because we might not know what all the risks are to be able to explain to patients. So what are some of those risks? So I guess first is that the, in inverted commas, de-identified data isn't de-identified as well as we think it is. A couple of years ago, the government put up a subset of Medicare data, so included medical services under the Medicare Benefits Scheme and drug prescribing under the Pharmaceutical Benefits Scheme, or the MBS and the PBS respectively, and it was 30 years worth of data for 10% of the Australian population. So every health service that you'd had, every time you'd seen the GP when it was covered by Medicare, every time you'd been to a Medicare rebated allied health service, every drug you'd been prescribed. This was de-identified in a number of ways. Medicare numbers were obscured using cryptography, so it's called hashing the numbers. The birth dates had the day removed, so it was only month and year of birth to try and reduce the ability for people to be re-identified based on their birthday. And also the Medicare provider ID was also encrypted, so people couldn't identify individual doctors who had been providing particular services. The Department of Human Services published the way that they'd encrypted the data along with the data set, and that then allowed the computer security researchers, who were the providers of the previous quote, to actually decrypt the provider number identities in that data set. Now, the implication from that was that they could also de-identify the patient ID numbers, and that's subsequently what went on to happen. So people say, well, it doesn't really matter if people know that I went to the doctor on the 1st of January or that I got a prescription for my statin on the 1st of March, because it's not the health record, it's not what I spoke about with my doctor, it's not privacy intrusive, it's just the fact that something happened. In terms of non-healthcare data, you might have heard it spoken about as being called metadata. So it's not what you discussed, but it's just the fact that a discussion happened. Now, this picture that I've got here from the 30C3 conference back in 2013, which is a computer security conference, shows a couple of examples of just how this argument is not true, that the very fact that you've had particular sorts of discussions or discussions with particular individuals can potentially be very privacy intrusive. For example, seeing a sexual health physician, there's a fairly limited number of things that you will have discussed with them. In the example of, for example, commercial pilots, seeing a psychiatrist, if you have a mental health condition, that's potentially a contraindication for being able to have a commercial pilot's license. So the very fact that that service exists is potentially privacy intrusive or stigmatizing, even without knowing what any of the details are. And obviously you can put the pieces of the puzzle together. So for example, if you've seen a sexual health physician and received a prescription for a medication that's only used for HIV, then it's pretty easy to be able to guess that that means that you've got HIV infection. Or similarly for drugs like RU486 that are used for medical termination of pregnancy, then the fact that you've been prescribed that medication means that you've had a particular procedure. What other ways can this data be used to potentially breach patients' privacy? So even without decrypting the provider numbers, if you've got a big data set, you can do some tricky statistics on it. So for example, if you look at the doctor identities that prescribe lots of drugs for HIV, then those doctors are probably one of the professional groups that I've mentioned there. So you can then say that any patient who's seen one of those doctors has a pretty good likelihood that they've got an infection or some sexual health condition. So you don't necessarily need to have clever encryption techniques to be able to use these sort of data sets to breach patients' privacy. One of the other ways of what's called frequency analysis is about frequency of the encryption items. So for example, you might say, well, my surname is Smith, so nobody could ever find me in the data set. But what you do then, instead of looking through the data set for all records, you look at the surname field, even if it's encrypted, that occurs most frequently, and that then is your encryption for Smith, because you know that Smith is the most frequent surname in the Australian population. Therefore, you can search your data set only in the patients whose name is obviously Smith, even though you haven't been able to break the encryption. The other way of re-identifying data, other than doing these sort of frequency analysis or data linkage, is by linking them with other data sets. And obviously this is what data linkage is about, and it is the important research outcome that we get from data linkage. But it's also important to recognize that linking one set of data with another set of data increases the likelihood that you'll be able to re-identify an individual based on what's in there. A couple of years ago, a member of parliament was left question time acutely because he had acute appendicitis. So if you wanted to search for that individual and then be able to identify what all of his records are, you look for a male in his 50s, because of course all our politicians are males in their 50s, who had one of the Medicare item numbers for an appendectomy. There's only 5 hospitals in the ACT, so you've got a pretty good idea where it happened, and we know that it happened on a particular date because it was reported widely in the media that Minister Bloggs had an appendectomy and he had to leave question time. So based on those few bits of information, you can very confidently identify the health records of that individual, and then if you think about linking that back, whether they've been prescribed an HIV antiviral or whether they take valacyclovir for herpes, that is potentially a way of breaching that individual's privacy. Of course, it's worse for women because everything is worse for women. So if you think about being a female of a particular age with children of your children's particular ages, it's very unlikely that there is another combination of those events occurring at the same time, and therefore people are able to search through the data set on the basis of when you were born, when your kids were born, and potentially re-identify you with a higher degree of confidence. The next potential risk to your privacy is the storage of this linked data. So the graphic on the right, you can see these are major reported data breaches just going back to 2016. The Marriott Hotel one, which is one of the largest data breaches ever recorded, not only included your name and date of birth and other details that you write down on the hotel sign-in form, but also your passport number, your credit card number, and various other bits and pieces of details. And the other graphic there is an SMS I just received last night while I was preparing this talk from the Early Warning Network, who provide severe weather alerts because I live in far north Queensland and am interested in cyclones. People who work in computer security think about data breaches as a when, not if event. So we should be preparing for the fact that a data breach will inevitably occur, not saying, oh, don't worry, it's not going to happen. And you can see the examples there that there's been very, very many data breaches over time. What about in the health and government space? So the Red Cross, 550,000 Australian blood donors, had all of their donor questionnaire details, including, have you ever had sex with a man? Have you ever had sex with a sex worker? All these sort of questions made available on the internet. There was an incident in 2017 where a healthcare worker was selling patients' Medicare numbers for identity fraud purposes. Just recently, it's been reported that there's been a number of data problems with My Health Record. In terms of government data, that someone accidentally managed to leave a spreadsheet of every member of Parliament's mobile phone number available on the web, so every Australian MP had to get a new mobile phone, and there was also tax details of more than 50,000 members of the Commonwealth Public Service made available on the web. Data breaches do happen, and they do happen frequently. And collecting this sort of data for health research increases the likelihood that at some stage in the future the data will manage to make its way into the wrong hands. So one of the other risks of data linkage is data linkage. That sounds trite, but there are firms who make their profit out of linking data from all sorts of different sets that they find around the internet. So your credit card data from banks, your social media data, your emails, your health service data. And what they do is they aggregate this data and then they sell it to banks or financial services institutions to assess your credit rating. They use it, of course, to do advertising to you. This is Google and Facebook or ad companies who provide services, not social media or search engine companies. As I've said there, that this isn't really misuse of data. It's not the intended purpose of the data, but that's actually what data linkage is about. It's about looking for insights in data for a different reason that it was collected. And so data linkage potentially has downsides as well as upsides. And of course, other than just people selling your data for credit ratings or for ads or whatever, the more companies who hold this sort of data about you, the greater the potential for one of them to have a data breach is. Health insurance companies have already been on the record in Australia saying that they like access to My Health Record data so they can improve the services that they provide to you, which of course means so they can make more money for their shareholders by paying out less premiums. And of significant concern in the data space is that GlaxoSmithKline have recently purchased the genetic sequencing company that I mentioned before, 23andMe. So they're obviously going to combine all this genetic data that they have with their pharmaceutical data to do pharmacogenomic research. I've already said most of the points on this slide, that really data linkage is about linking data together, and linking data together potentially allows insights to be gleaned from that data, but it might not always be the ones that we're looking for in terms of health research. And this is what we call, I think, a dual use technology, which is, so microbiology research, for example, where you can use it for health research, or you could also use it for bioterrorism as a dual use research. And I really think we need to think about data linkage in this same way, that there are potential benefits, but there are also very significant potential side effects. And that one of the things about having these research data sets is that we want to make data more available to people so they can do research. The downside of it is that making data more available to researchers also potentially makes it more available to people who might misuse the data. So I've just got a slide here on some of the potential consequences of data linkage research. Now, in Australia, we have very strict laws that say that private health insurance companies aren't able to refuse cover on the basis of your pre-existing conditions. However, that's not the case in the United States, and managed care in the United States is a big issue. There's what's called step-up therapy, where HMOs, health management organisations, won't fund more expensive therapies for particular conditions unless cheaper but less effective therapies have been tried first, on the basis of the fact that they may get away with paying less for the cheaper therapy and it might just work. So what if this sort of linked data research is used for health care management? So, for example, you have got a high risk of mortality based on your hospital admission data that's been calculated by your Google analysis of your medical records. Therefore, because you're going to die during the hospital admission, we won't give you the expensive treatment, we'll give you the cheaper one, because it's probably not going to make a difference anyway. Now that's an ethical slippery slope argument, which is always a bit of a lazy option to do, but there is a very significantly different culture of health management in America than there is in Australia, and these are some of the potential flow-ons of this sort of data linkage research. In terms of the specific example of what we're talking about today, being colonised by a drug-resistant organism is definitely definitely a risk for having a drug-resistant infection. So does that mean that your insurance company can consider that it's a pre-existing condition and refuse to use coverage even just for 12 months, which is quite legal under Australian law? Who knows? And similarly, what about the data that's able to be gleaned from your linked data that isn't necessarily related to your health conditions? Again, using one of the examples from my work in sexual health, you've had 7 or 8 sexual health screens in a year. That means you're obviously having lots of risky sex. So I guess if you get HIV, that's probably your fault for not using condoms, isn't it? So we're not going to cover you. These are the sort of ethical issues that we need to grapple with, and I know there's another talk coming up soon about the ethical issues in data linkage. So in terms of my conclusions, data linkage is happening. It happens all the time by advertisers, by healthcare organisations, and we just really need to understand the technology very well. I do believe that data linkage research has the potential for major health benefits, but that in general, we understand the risks very poorly and are often downplayed by researchers, partially because they don't understand them, but partially because they want to get on and do their research. Collection of data is a cumulative and ongoing and additive privacy risk. The more data we collect, it will eventually get out, and that really linkage research is a dual use technology, that there are potential downsides and the potential for industry largely to misuse it, as well as the health benefits that we get from it. And the question that we really need to ask ourselves is whether the benefits justify the risks of using it. I'll make myself available for questions as part of the panel following the presentations, and if you're interested in reading any more about this sort of stuff, we've written quite a number of articles on our FutureWise blog, which I've got the website there for, and we don't advertise on our website, and I don't get any financial kickbacks for advertising to you. So thank you for your time.